Hello, my name is Quentin Broussard. I am an Associate Professor of Clinical Sciences at Keck Graduate Institute, and today we will be discussing sepsis and septic shock. So, our objectives today are going to be to define what sepsis and septic shock are. We're going to review the different elements of the different sepsis guidelines over a little bit over the past decade, starting with the 2012 Surviving Sepsis campaign guidelines and what those guidelines place and bundles place are in practice with the 2016 and the 2021 Surviving Sepsis guidelines, which are the more recent Surviving Sepsis guidelines. And we're also going to determine appropriate antimicrobial and supportive treatment options for patients that have sepsis and septic shock. First thing we're going to start off with today is a case. We have patient AF, a 72-year-old male who presents to the emergency department with altered mental status, dysuria and hematuria over the last 24 hours, a current fever of 102 degrees Fahrenheit, and hypotension with a blood pressure of 70/40. Upon initial assessment, he has a Q-SOFA score of 2 and a change in SOFA score of 2 from baseline. The patient hasn't received any treatment yet, and the lactate level is pending. Per sepsis 3, which of the following is the most appropriate diagnosis for the patient AF at this time? Infection, sepsis, severe sepsis, or septic shock. The next question corresponds to the same case. To treat patient AF's underlying infection, the ED physician would like to start an antibiotic. Which antibiotic should be initiated empirically to treat the patient? Ceftriaxone, gentamicin, meropenem, or vancomycin? To attempt correction of the patient's hemodynamic instability, the ED physician would like to start fluid resuscitation for patient AF. Which IV fluid should be used first to resuscitate the patient? Albumin, dextrose 5% in water or D5W, hydroxyethyl starch, or lactated bringers. So, after reviewing sepsis and septic shock today and the materials that are in this PowerPoint, I'm hoping that you will be able to answer each of these different case questions with confidence. The first thing we'll start off with is just a little bit of background about sepsis. So, sepsis is actually estimated to be the leading cause of mortality and critical illness worldwide. And that's a quote taken from a journal article. There are greater than 750,000 sepsis cases annually, and I believe that's just in the United States. That's not necessarily worldwide, with an estimated 15 to 35% of hospitalized patients having sepsis or septic shock. So that's actually a very, very big number. Sepsis is one of the diagnoses that is the most common in the hospital. So that's why it's very important to be aware about the treatment modalities and the empiric treatments for how to go about treating sepsis, and then downstream, tailoring the therapies for the patient depending on, what type of infection they have and what the culture's result as. Over $20 billion was accounted for in regards to overall hospital cost and sepsis in 2011. So you can only imagine by now, and this video recording is being recorded in 2025, that that's probably well significantly higher, especially after the COVID pandemic, where COVID actually influenced a lot of patients to actually have sepsis out in the hospitalized areas. And because of that, it's probably, significantly higher than this. And it's said that the mortality rate for sepsis is 1 in 4, and sometimes often more. So this will depend on the patient population that is at the hospitals. It'll also depend on the hospital's compliance with the bundles and the treatment modalities that we're going to talk about today, with sepsis and septic shock specifically. So, what is sepsis? So, sepsis is highly complicated and it's not very well understood in some ways, forms, and fashions. Sepsis is essentially a syndrome, which makes it different than other disease states that you may have learned about previously. Um, the main core things that happen in sepsis, though, is that sepsis always begins with an infection. You always have to have an infection to have sepsis. What happens that makes an infection eventually lead to sepsis, because not all infections will lead necessarily to sepsis, is that the infection progresses, and this can be due to a variety of different reasons. Either, the bacterial or the pathogenic load of that um, infection is very high in the patient, where that pathogenic load basically spurs on the infection to progress and generate an inflammatory response in the body, or additionally, where the patient's immune system may not be able to fight off even the simplest of infections. So I kind of look at it as a seesaw in regards to, how much pathogen is there, and, the patient's ability to fight off whatever the pathogen actually is. So if you have somebody who has a high pathogen load and a bad immune system, for example, it's probably not going to, be um, as easy of a treatment compared to somebody who has, a good set of immune factors in their body and has a low pathogen load. So, depending on how the seesaw actually goes, with sepsis, infection progresses, and what that leads to is a big, large inflammatory response in the entire body, and that leads to host tissue damage. What happens whenever that host tissue damage actually happens is that we have our body's anti-inflammatory response happen, which activates leukocytes and a whole bunch of other inflammatory mediators to go basically to that side of infection, but also to be stimulated throughout the rest of the body. And as a result, the control of the inflammatory process is lost, because that inflammatory process that usually protects an immune competent person is unable to kill the pathogen, or basically the entire pathogenic load outright. And as a result of this, our bodies actually generate what are known as a systemic inflammatory response syndrome, or SIRS. And we'll talk about what SIRS actually is in a little bit. And that SIRS, is basically the sign that your infection is a little bit more severe than just a general infection. And that's really where the diagnosis of sepsis and septic shock happen. This is just a little bit of a graphic to basically show you exactly kind of, what happens in regards to whenever a patient is exposed, in this case, to a gram-negative bacterium, for example, E. coli, and kind of more or less summarizing what we talked about on the last slide with exposure to the bacteria in the body, and then your body's actual response to that by activating a large immune response that may or may not be able to kill some of the pathogen, but definitely not kill all of the pathogen, leading to endothelial damage and then a general inflammatory response and sepsis. So I know that that's very confusing, but whenever we actually go through the actual presentation, it'll be a little bit more concrete in how this actually plays out in terms of the presentation of the patient. Whenever we're looking at the patient specifically for sepsis, there's a large variety of symptoms that can actually happen. And keep in mind that sepsis is a syndrome. It's a constellation of symptoms. It's not necessarily, a concrete disease state where you might, have, the same symptoms occur for every patient. Every patient that develops sepsis is going to be different in what they actually present as. So some patients may have altered mental status, some may not. Some may generate systemic inflammatory response syndrome criteria, and some may not. We'll talk about that in a moment. Some may eventually develop hemodynamic instability, which I'm going to define as here as hypotension or a systolic blood pressure less than 90 or a mean arterial pressure of less than 65. Mean arterial pressure is just 1/3 times systolic plus 2/3 times diastolic. And tachycardia can also be included in hemodynamic instability, a heart rate of greater than 90 or a heart rate of greater than 100, depending on which definition you look at. It can um, represent as a acute respiratory distress syndrome in some patients. It can also, damage organs as other organs as well, such as the kidneys. You may, get lack of blood flow to the kidneys because of this large inflammatory response that's happening. What happens in that large inflammatory response is that a lot of vasodilation happens in the body, and the blood pressure in some of our patients will actually drop. And because that blood pressure is dropping, our bodies usually prioritize brain and heart as its two organs that are going to be, the most important for receiving blood. So unfortunately, when the blood is flowing in our body, the kidneys are not going to be getting as much blood as they're used to. And they're used to usually getting about 25% of our cardiac output in general. So if they're not, getting that 25% of cardiac output that they usually get, what's going to develop is in patients that have had normal kidneys beforehand, they can actually develop what's called acute kidney injury. And they can develop oliguria or low urine output of less than 0.5 mils per kilo per hour, or anuria where they have no urine production at all. And depending on the patient, if they've had, maybe previous instances where their kidneys have been damaged beforehand, sometimes that might lead to chronic kidney disease and even end-stage renal disease where they have to be on permanent dialysis. Sepsis also leads to something called disseminated intravascular coagulopathy, or DIC. The way that I think about disseminated intravascular coagulopathy is you clot first and you bleed later. So if you think about the inflammatory response, the inflammatory response of the body is sending out large amounts of inflammatory mediators, including, white blood cells and platelets also. So you might see in some patients initially that they might actually have an uptrend in platelets from whatever their baseline might actually be. But at a certain point, the bone marrow is not going to be able to produce enough platelets to meet the demand of that inflammatory response. And as a response to that, you're actually going to see a drop in platelets, or what's called thrombocytopenia. And that thrombocytopenia is usually defined as a platelet count less than either 150,000 or less than 100,000, depending on what reference you're looking at. And whenever you are not able to produce as many platelets, that can lead to, an increased risk of bleeding, particularly in terms of the GI tract. So gastrointestinal hemorrhage can happen. We also can see patients that have acute liver injury also from the same concept of if you're not getting enough blood flow because of that large vasodilatory response that's happening in the body that's prioritizing the heart and the brain, you can then basically damage your liver also, and that can basically result in your ALT, your AST, your alk phos all becoming elevated. Primary emphasis on the ALT because that's the one that's most specific for the liver. A lactic acidosis also results a lot of times from sepsis, and remember, lactic acidosis is a type of anion gap metabolic acidosis. With lactic acidosis, remember that lactate is a byproduct of anaerobic metabolism, and sepsis, because it causes a large inflammatory response, drops our blood pressure. It actually is a syndrome that is a um, mismatch between oxygen supply and oxygen demand. So, our bodies, because we're, in a septic patient, they may become vasodilated. They might not be able to deliver blood to all the other organs as, appropriate. And that actually generates a higher oxygen demand for our patients. And as a result, a lot of the metabolism that's happening in the body actually shifts from aerobic to anaerobic, where basically lactate is produced. And that's one of the most common things that actually happens in sepsis. There's also many other complications that can happen from sepsis also. So overall prognosis, mortality rates are obviously very high based on what I just described previously related to sepsis. And they can obviously be higher in patients that have comorbidities. For example, advanced age, so the older the patient, maybe they've gone through, a lot of things in terms of the disease, other baseline disease states throughout their lives. And, as people get older, sometimes organs can sometimes become, a little bit weaker. One thing that we commonly think about is kidneys. Chronic obstructive pulmonary disease patients don't tend to do as well as those that don't have COPD. Cancer patients or patients that have malignancy don't tend to do as well. HIV or AIDS. Patients that have more failed organs or maybe might have more failed organs at baseline. So if you have someone who already has cirrhosis or liver disease or, end-stage renal disease beforehand, that's, sometimes not a good prognostic factor. It doesn't necessarily mean that, they won't be able to get out of the woods of sepsis. It just means that they're probably going to have to fight a little bit harder in terms of, everything going on. Positive blood cultures, which we commonly see in sepsis, Pseudomonas infections and other multi-drug resistant organism infections are also, prone to have higher mortality rates. Intra-abdominal infections secondary to ischemic bowel. And, if you think about the vasodilatory response that happens, blood is also shifting away from the gut, because it's prioritizing heart and brain. So if you shift blood away from the gut, you develop basically what's called an ischemic bowel. And that means that the bowel is not getting enough oxygen. The bowel starts to actually die because of that. And whenever the bowel becomes necrotic, that is, a reason to actually go and do source control if possible to take part of that bowel out that might be gangrenous. And whenever you have somebody who has, multiple organs, the mortality increases very significantly. Whenever you have two failed organs, the mortality rate is about 29%. Whenever you have five failed organs, the mortality rate is 65%. So it's a very, very big deal, to try and, if possible, reverse this process from happening. So, what are the actual sepsis definitions? Like, how is sepsis actually defined? How is it diagnosed? It's really highly debated, and we're going to kind of go through a few different schemes of how things have been defined with sepsis in the past. So in 2012, the 2012 guidelines basically emphasized many different variables, including SIRS criteria. And the SIRS criteria are actually listed here. And this is a very important point to know about because even though these guidelines were published in 2012 and there's been two different iterations of the guidelines after that, people still use SIRS criteria and they are still a hallmark of things that we see in sepsis. SIRS criteria do include temperature greater than basically 100.4 degrees Fahrenheit or less than 96.8 degrees Fahrenheit, a heart rate greater than 90, and in some cases, some people might say 100 in this case, respiratory rate greater than 20, or a PaCO2 of less than 32, a white blood cell count greater than 12,000 or less than 4,000 or greater than 10% immature bands. Now, the thing to know about SIRS criteria is that SIRS criteria are just what they sound like. They are an inflammatory response set of symptoms. So there are other reasons other than infection that you can have SIRS criteria. It does not mean that if you have SIRS criteria, you have sepsis. You always have to have a baseline infection to have sepsis. So other places where we actually see SIRS criteria, but we don't necessarily have infection are cases where patients might be post-surgery, where they were already in fight or flight more or less during the surgical process. And, they have basically a response happen, like heart rate and respiratory rate being elevated potentially. You might see it in patients that have pancreatitis. Pancreatitis is just inflammation of the pancreas, and it's not necessarily always infectious. You might also see it with patients that have severe burns. Just because a patient has a burn doesn't necessarily mean that they are infected. Sometimes they are, sometimes they're not. So, as I alluded to with the 2012 sepsis definitions, sepsis actually is going to be classified as two of those SIRS criteria that we talked about on the previous slide, plus a diagnosed or a suspected infection. So if we don't know what it is yet, and we have two SIRS criteria, we're going to call it sepsis until we can't call it sepsis. And we're going to treat it as if it's sepsis because we don't want to take the risk of not treating it. 2012 guidelines also define something known as severe sepsis, which was known as sepsis-induced hypoperfusion, or a minimum of at least one organ dysfunction. So what that basically means is you can either have an organ dysfunction that is basically listed here, like hypotension, a low urine output, which would be kidney dysfunction, acute lung injury, a serum creatinine greater than 2, a bilirubin greater than 2, which would, hint at liver dysfunction, platelet count less than 100,000, a coagulopathy or an INR greater than 1.5. So there are cases where we see patients that have elevated INRs that are not on INR elevating medications like warfarin. So that's a very important point to note here. You also have sepsis-induced hypoperfusion, which is the other piece. So if you have a lactate greater than at least 2, you already know at that point that anaerobic metabolism is, occurring at a higher level than it is usually. And because of that, then we need to basically address it. Severe sepsis can eventually then lead to septic shock. And septic shock is sepsis induced hypotension persisting despite adequate fluid resuscitation, or just a lactate greater than 4. So it can be either a lactate greater than 4, or it can be basically hypotension despite giving them adequate fluid resuscitation, which we'll talk about in a moment. Now, that was the 2012 guidelines that we had talked about on the previous slide. There was a document that followed that called Sepsis 3, and this was published in 2016 in February. And again, it's highly debated. It redefined what the definitions for sepsis and septic shock were. So they defined sepsis as a life-threatening organ dysfunction caused by dysregulated host response to infection. That's a quote. And they define sepsis, septic shock as subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. So that last definition is kind of very broad. But what I kind of want to direct you to is that, with the previous 2012 definitions, that sepsis didn't necessarily involve organ dysfunction. Remember, sepsis in the previous definitions was just two SIRS criteria plus either a confirmed or suspected infection. So basically, it kind of shifted the threshold for classifying or diagnosing sepsis to the level of what severe sepsis was in the previous guideline. And as a result of that, and the fact that the next logical step in the process was septic shock, they actually eliminated severe sepsis as a diagnostic definition in the Sepsis 3 document. And that Sepsis 3 just means that it was the third definition of how they defined sepsis. The other definition was defined previously, and highlighted in the previous guidelines. So the main thing that we kind of focus on now in terms of diagnostics is sepsis 3. We usually don't use the term severe sepsis anymore, though you will still see clinicians out there that might still use this because that's what they're used to, and that's, perfectly okay. But for appropriate diagnostic purposes and for coding purposes, if you're in America, for example, and you're using, ICD-10 codes for coding, you're probably going to be using sepsis or septic shock, most likely. And that can obviously vary depending on, how you're coding things. So, how do we actually go about actually identifying sepsis or septic shock? So, if we have an infection suspected, at that point, to determine if it is sepsis or septic shock, what we can do is calculate a Q-SOFA score. And a Q-SOFA score is basically based on three different criteria. A respiratory rate greater than or equal to 22 breaths per minute, an ultra mental status, or a systolic blood pressure less than 100. So I kind of think about Q-SOFA as kind of similar to what SIRS was in 2012 guidelines and before that. However, with QSOFA, you see that there was only kind of one parameter that was shared, and that's the respiratory rate. And with SIRS, it's really respiratory rate greater than 20-ish. QSOFA is respiratory rate greater than 22. So you see here that there's a little bit of variability, and most likely it's because they didn't want to mistake somebody who did have a, respiratory rate of 20 or 21 or something along those lines of, potentially being septic. So they upped the threshold a little bit. So whenever we're looking here, they use QSOFA because they based it on a lot of data that they had that, corresponded with, sepsis or what they thought to be sepsis at that point. So if they have a QSOFA score of two or more, once you actually add up if they have these three criteria or not, if they have two or more of those criteria, then you proceed to calculate what is called a SOFA score. And what a SOFA score is a SOFA score is based on multiple factors. It is basically just the sequential or sometimes what they call sepsis related organ failure assessment score. It's multiple factors. For each different factor, there's a score of 0 to 4. And a total score change of 2 or more from baseline indicates that the patient has sepsis. So it indicates that the patient has actual organ dysfunction, and that organ dysfunction is likely probably related to their infection. Sometimes it might not be. If the patient, had a suspected infection and then, the infection actually got ruled out. This SOFA chart is not important necessarily for you to know in regards to each individual component and what score each different, um, component actually has related to it, but just know that a change of score of two or more from the baseline indicates sepsis. A lot of hospitals actually use their own electronic medical records to actually help in calculating this score because you see its multiple components, and it sometimes takes a little bit of time to actually go through and calculate this. Now that we've gone through and gone about diagnosing sepsis based on sepsis 3, if the patient, after diagnosing sepsis and receiving adequate fluid resuscitation, if they have to be put on vasopressors to support their blood pressure or their MAP, arterial pressure, and they have a serum lactate greater than 2, if they meet all three of these criteria above, they have at that point a diagnosis of septic shock. So you basically have to go a little bit of ways to actually get to the diagnosis of septic shock. So since sepsis 3, a lot of institutions actually shifted to using that QSOFA score initially as a way to start screening patients for potential sepsis. And what that Sepsis 3 document was meant to do was to diagnose sepsis, probably more so after it, was already screened for. And every hospital has a different way of screening for sepsis, whether that be something that's evidence based here, that's listed in the guidelines in Sepsis 3, in other documents. Sometimes people look at certain service criteria, sometimes people look at other factors. Um, but basically, people started using this QSOFA score and actually using it to screen for sepsis, but that wasn't really what was really meant by the QSOFA score originally. It was meant to diagnose it, but whenever we're screening for something, usually we're trying to see, is there a possibility that they have it? versus fully diagnosing it. So basically, the new guidelines in 2021 basically came out with a recommendation that said we recommend against using QSOFA compared with SIRS as a single screening tool for sepsis or septic shock. They really want you to look at a little bit of everything. And what they actually mentioned, in the guidelines is that only about 24% of patients with an infection had a QSOFA score of 2 or 3. So it wasn't very specific to sepsis in general. But again, remember, sepsis is a syndrome, a constellation of symptoms, and no one tool will always be able to screen or identify for sepsis or septic shock. So usually it's gonna be based on, obviously the evidence that we have here, but sometimes it's going to be based on clinician judgment and clinician's experience as to whether or not a patient could have sepsis or not. And as we kind of talked about earlier, if there's even a possibility of sepsis, you're going to treat it like sepsis until it's basically ruled out that it's not sepsis and it's something else. Because constellation of symptoms can be a wide variety of things for a wide variety of disease states. In terms of sepsis treatment fundamentals, so this is the main crux of what we're going to be talking about moving forward. We're going to actually obtain cultures first if possible, and we're going to promptly administer empiric antimicrobials, most of the time antibiotics. We were going to want to determine where the possible infection source is, because any infection, if there's a high pathogen load or if we have an immunocompromised patient or both, can potentially generate sepsis. We're going to do always source control if possible. If you have an infection that has a high pathogen burden, antibiotics or antimicrobials are not going to be able to always kill it on its own. We want to always also treat the most likely pathogens related to the possible source. So, depending on the assessment of the patient, the physical assessment, the labs, what we actually see sometimes on, radiographic imaging like chest x-ray or CT scan, we want to take a look at those things to actually see what is actually going on in terms of what's the most likely source of infection, and then treat using antimicrobials that are going to target those specific infections, as we'll see in a moment. We want to always give fluid resuscitation if the patient is either hypotensive or their lactate is greater than 4. And, some places will also obviously, do fluid challenges if the lactate is greater than 2. Just because we want to try to lower that lactate down to the point where we're shifting the body back to an aerobic metabolism setting. If we need to administer vasopressors, we can do that if the patient's hypotensive and not responsive to initial fluids. If the patient is not responsive to fluids and to vasopressors, we can also give corticosteroids like hydrocortisone. If the patient has a cardiac dysfunction component where they either have a low cardiac output or a low cardiac index or a low SCVO2, we can give inotropic agents that stimulate the heart to actually increase its output. And there also might be other supportive care measures that we're also going to be doing for patients too. So everything with sepsis is really based on the bundles that we're going to talk about that were actually published in the 2012 guidelines. So the future guidelines actually address these same things, but the crux of what we do in sepsis is based on these bundles. And there's basically a 3-hour bundle and a 6-hour bundle. So the original 2012 guidelines said for the 3-hour bundle, what we're going to do is these 4 things. We're going to measure a lactate level. We're going to try to obtain blood cultures prior to the administration of antibiotics when possible. And in addition to that, obviously, we're going to want to try to obtain cultures of other potential sources of infection. But it's always required for any sepsis presentation or potential sepsis presentation to get blood cultures. Usually those are 2 blood cultures from 2 different IV sites. Administer broad spectrum antibiotics. Now, this is the big point here. It usually needs to be, or it must be, I should say, within 1 hour of a sepsis septic shock being confirmed or sepsis or septic shock being probable. I put that there because the newer guidelines kind of point to differences in regards to the time length, but for our purposes, and what's going to be always best practice is if you have a possibility of sepsis, you're going to do it within 1 hour. And then, as we talked about, if your patient develops sepsis induced hypoperfusion, which is basically in this case going to be hypotension, or in this case, a lactate greater than 4 millimoles per liter. Some places may use milligrams per deciliter for lactate, which is just a ninefold difference between the two. 4 times 9 is 36. Then we give 30 mils per kilo at minimum of crystalloid solution within the 3 hours of sepsis septic shock identification or the possibility of it being existing. Surviving Sepsis Guidelines of 2012 also had a 6 hour bundle. And what the 6 hour bundle said was give vasopressors for patients that had hypotension that does not respond to initial fluid resuscitation. And there's obviously going to be updates to that as we keep going on. In the event that the patient still has persistent hypotension despite adequate fluid resuscitation or lactate greater than 4, we're going to measure what's called a CVP and a central venous oxygen saturation. And that is just basically measurements of fluid responsiveness is what we will say that those are at this time. CVP is basically, the pressure that's kind of being generated back toward the heart and the venous circulation. The central venous oxygen saturation is more or less just the oxygen saturation that is being returned back to the heart from venous circulation. Additionally, we also, if we had an elevated lactate initially, for example, like greater than a 2 or greater than a 4, we want to remeasure the lactate if the initial lactate was elevated. And our goals here, in terms of quantitative resuscitation, were a CVP of greater than 8 in the guidelines of 2012, SCVO2 of greater than or equal to 70, or normalization of lactate, basically where it was less than 2. So the Surviving Sepsis Guidelines of 2016 updated things a little bit. So they didn't necessarily address everything as bundles in the 2016 guidelines, but they pretty much kept most of the elements of the 2012 guidelines, the exception being step 6, where they did not necessarily mention or address having a mandated requirement for obtaining CVP and SCVO2, that those are still commonly done, particularly CVP. The 2016 guidelines focused on looking at a bunch of different parameters to assess fluid responsiveness, because even CVP and SCVO2 are not going to be always adequate measurements of fluid responsiveness. So there's a lot of different things that can be looked at: blood pressure, urine output, cardiac index, stroke volume, lactate clearance, raising a leg passively. And if you have basically a response in blood pressure to that, it might mean that your patient might be responsive to fluid. Capillary refill time, and there's many others that are, out there also. So going back to the bundles, the next thing that we're really going to address outside of the lactate level, which we mentioned is basically a measurement of hypoperfusion, is the obtainment of blood cultures prior to administration of antibiotics and administration of broad spectrum antibiotics. Now, the 2016 guidelines say specifically, the quote here, that they recommend that appropriate microbiological cultures, including blood, be obtained before starting antimicrobial therapy in patients with sepsis or septic shock, if doing so results in no substantial delay in the start of antimicrobials. So, for example, if you're trying to basically get a blood culture and you can't locate the blood culture tubes, or you're having other things happen that basically can prevent you from drawing the blood. If you got to give the antimicrobials, you got to give the antimicrobials. I'm going to tell you straight up that antimicrobials are one of the, big hallmark things that help reduce mortality in sepsis. Because remember, sepsis at the end of the day is based on an infection. And if you have an infection, giving antimicrobials is the thing that's going to lead in net to reducing mortality. and this in the 2016 guidelines is best practice. In the 2021 guidelines, they kind of vary things a little bit. And if you read the statement, it kind of sounds similar to what we talked about earlier with 2012, in that, we're still wanting to give antibiotics within 1 hour, but they say here, if you have possible septic shock or a high likelihood for sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour of recognition. But they say it's a strong recommendation, and they say that there's a very low or very low quality of evidence. So now what the surviving sepsis guidelines are saying is that if shock is present and you're even at the possibility of sepsis, to give it within 1 hour. But if you don't have shock there, where basically your lactate's greater than 4, you're hypotensive, at that point, if you don't have any shock, if you have probable or definite sepsis, they say within 1 hour antimicrobials should be given. However, if sepsis is, quote, possible, that you should go and do the assessment of the patient to see if they're infectious or not. And then they allow for a 3 hour window for those cases. I kind of think that this can kind of be a little bit confusing and misleading to some people that might read this initially. So, what I always tell people, and advise people about is you want to, if it's even a possibility, to try to give the antibiotics or the antimicrobials as quick as possible, because that's honestly what's going to, potentially save the patient at the end of the day. And there's actually data related to mortality benefit in regards to the quicker that we give antibiotics. So what this chart actually shows here is basically a time of hypotension onset on the x-axis versus a fraction of the total patients on the y-axis, and what their survival fractions were compared to basically them getting antimicrobials initiated. And what they found in this particular study was that, with every 1 hour that went by where a patient did not get antibiotics, there was an 8% increase in mortality. So if you think about that over 12 hours, you're up to around 96% mortality. And at 13 hours, you would theoretically be above 100%, but things don't necessarily work that way. It kind of works on a sloped curve instead of a, linear progression necessarily, because depending on the patient, depending on their pathogen burden and their ability to fight off the infection, miracles can happen. And ultimately, at the end of the day, this messaging just says give the antibiotics as quick as you can, because every moment counts. Every moment being, with every 1 hour elapsed, an 8% increase in mortality. So I still believe that it's best to give our antibiotics as quick as possible, even despite there being conflicting evidence out there. When we're choosing antimicrobials for treating patients in sepsis, we want to select the antimicrobials based on the infection site, what the most likely pathogens are related to that infection site, whether the infection is considered to be community or hospital acquired, meaning hospital acquired infections are going to be infections that occur greater than or equal to 48 hours after hospital admission. Or if a patient is exposed to a healthcare facility, usually in the last 3 months. So if they're in a long-term care, a nursing home, a long-term acute care facility, something along those lines, and they've been there and they, within the previous 3 months before the current admission, I would maybe consider treating them hospital acquired. The patient's immune status. If a patient's had recent antibiotic exposure within the last 3 months, you might want to ramp up what you do and maybe avoid the antibiotics that we've, maybe used before potentially. And additionally, the antimicrobial susceptibility and resistance profiles per each institution, because every institution will be different. We want to give, optimal dosing based on pharmacokinetics and dynamics, and that's something that's consistent in the 2016 and the 2021 guidelines. We want to optimize based on the kinetics of the drug. So obviously, high dosing and frequent dosing when appropriate for the antibiotic. And then we want to de escalate things after a few days once we've gotten cultures back, once we've seen potentially clinically improvement and evidence of infection resolution. So, for example, if a culture is positive to specific organisms and we have sensitivities to that organism, use antimicrobial stewardship to basically tailor things down. If you're culture negative, did you actually have sepsis at the beginning, or maybe we didn't get a culture of a specific area like sputum from the lungs for a pneumonia patient? Are they still looking infectious? Do they have a white count? Do they have a fever? Do they have elevated heart rate? Do they have elevated respiratory rate? Do they have overall clinical improvement? Or did they get worse? And if they went worse, you might want to broaden things out a little bit. Potential sources of sepsis are all of our standard infection types. So you can technically get sepsis from any type of infection, but the most common ones are going to be the ones that you see here listed on the slide. We're going to focus primarily on all of the ones in the bullet points above others for the purpose of this talk today, but just know that endocarditis and meningitis will have their own separate recommendations, which will be discussed with you in another lecture. So the first thing we're going to go to is skin and soft tissue infection diagnosis. So whenever we're diagnosing these, obviously you can have a cellulitis or a redness around. You can have other more deeper type infections. Usually what's going to happen with these infections is that we're going to, want to obtain a gram stain of whatever that skin soft tissue infection actually is if we can, and culture for any obvious wound exudates or basically leakages. And if possible, obtain a needle aspiration of a closed infection like a cellulitis or an abscess, which is a general just drainage, or sorry, a general fluid collection. We're going to want to basically get that fluid so that we can gram stain it and culture it to see what it actually is, and we can get, microbial sensitivities. Now, the treatment for skin and soft tissue infection and the treatment really for any infection is always going to be source control first when possible. So, if we can clean that wound, if we can drain that wound, if we can debride that wound, debriding meaning, basically cleaning it up, maybe ripping some skin off that's, nasty and or infected looking, we're going to want to do that first. That is the source of the infection. We want to always source control it. Now, if you have a community-acquired infection, we usually think about gram-positive and MRSA being out in the community. So we're going to use our typical MRSA agents to cover. So you can use either vancomycin, which is the most common, linezolid, or daptomycin. I always tell people to be very careful with linezolid depending on the infection type. Remember, linezolid is bacteriostatic and daptomycin is bactericidal. So if you have to go to like a second, step, a lot of times clinicians might, end up going on the daptomycin end of things versus the linezolid side, especially if that skin soft tissue infection eventually hits the blood and then turns into what we call a bacteremia or a blood infection. Hospital-acquired infections for skin and soft tissue, we think about a little bit of everything. And this can kind of also apply in some cases a little bit to diabetic foot infections, which also tend to get a lot less blood flow. So in gram-positive coverage and MRSA coverage, we have the standard vancomycin adapto. But in terms of the gram-negative pseudomonal and anaerobic coverage, we're going to want to use agents that have coverage for those things. So the ones that are most common in practice are piperacillin tazobactam or Zosyn. Carbapenems that are not ergopenem. Remember, ergopenem does not have coverage for Pseudomonas. Or a combination of cefepime ceftazidime, either one of those, with metronidazole. Cefepime and ceftazidime don't have necessarily great anaerobic coverage, and the anaerobic coverage in that case is provided by metronidazole. Cefepime and ceftaz do have great gram-negative and pseudomonal coverage. If you have a patient that has certain types of infections, and this doesn't necessarily apply to all infections of the skin soft tissue, but sometimes some severe things like necrotizing fasciitis, where it's a very, very nasty, skin soft tissue infection, or a Fournier's gangrene, where it's almost kind of like a necrotizing fasciitis in the genitourinary areas and the anal areas. That's what Fournier's is. In those cases, sometimes clinicians will add clindamycin on, not just for MRSA and anaerobic coverage, but because clindamycin has, some potential evidence out there that it may inhibit toxin production of some of these types of infections. And Clinda overall, can sometimes be used out in the community also if you have, some mild MRSA infections that might have, the need for anaerobic coverage. A urinary tract infection, typically we're going to see things like dysuria, hematuria, change in frequency and urgency related to, patients urinating. Sometimes we see lower abdominal flank pain and flank pain. The flank pain happens a lot whenever the infection actually hits the kidneys, and we call that pyelonephritis. Usually for these patients, we're going to definitely want to obtain a urinalysis, and things on the urinalysis that might be, things that might be infectious related include positive nitrates, a positive leukocyte esterase, positive white blood cell count in the urine greater than 10, actually seeing bacteria or actually seeing, maybe even fungus or yeast in the urine, cloudy urine, and other things. And, if we do see, nasty things on the urinalysis, they will definitely obtain a urine culture. Now, the hallmark treatment for urinary tract infections is obviously source control at first if possible. So if a patient is at a long-term care facility, or if they have the need to basically have a pre-existing urinary catheter because they can't, urinate out on their own, these urinary Foleys or urinary catheters actually end up going into the bladder. And if you have something foreign in the body, they sometimes can accumulate different bacteria that's there. Remember, we only treat urinary tract infections if they're symptomatic. Obviously, sepsis is, something that is very symptomatic, so we're going to want to, treat it with antibiotics. But if you have someone who has, a Foley in, you always want to source control it and pull the Foley out and replace it if you have to. For community-acquired infections, we usually just think gram-negative organisms. Usually, we don't need necessarily the Pseudomonas coverage because Pseudomonas is not always commonly found in the community. So usually ceftriaxone or Herceptin is going to cover, most of the different types of urinary tract infections that, you might see out there. If you have a patient that actually does have a legit cephalosporin allergy, though, ciprofloxacin or levofloxacin can be used as an alternative, but caution for resistance there because, you have some areas that have high fluoroquinolone resistance. So you might, in that case, maybe escalate it up, a level. um, Hospital acquired infections, we also think gram negative. Most of the time, usually less than 5% to less than 1% of infections are actually, at least in the urinary tract, caused by Pseudomonas. So we don't usually necessarily always need the Pseudomonas coverage. I'm going to tell you straight up, what we usually see in practice is they will, almost everybody, that comes to the hospital except for the cephalosporin allergies will get ceftriaxone. But sometimes you can use ceftazidime also in addition to cipro or levofloxacin, as we previously talked about. Respiratory tract infections. So this includes things like pneumonia and other, associated respiratory tract issues that might actually be predisposing for an infection, like pleural effusions or other, things that might actually have, nasty infectious properties. Symptoms with respiratory tract infection, we're going to usually see shortness of breath, fever, cough, sputum production. We're going to always want to get a chest x-ray to identify a consolidation, an opacity, or an infiltrate. Those are the three common things that you're going to see on chest imaging if they are looking into a possibility of pneumonia diagnosis. COI is the way I remember it, or COI. Um, we want to obtain respiratory secretions for culture if possible. Sometimes that's not always possible, and I'll tell you straight up, it doesn't always work out because you're not able to get a great sputum sample from every patient. It's usually a small amount for what we really need for culture, and most of them will come out negative even if the patient is positive. In cases of outbreaks, you might want to get urinary antigens for Legionella, which is a very common atypical organism that might be out there, that may result in community-acquired pneumonia. We want to encourage incentive spirometry when possible. What that means is we want to basically encourage the patient to breathe in and out. Usually they'll do that with what's called an incentive spirometer, or a little, device where they can breathe in and out and try to basically push a little ball up, in a little tube. And basically, what that's basically helping to do is exercise the lungs. Because if you exercise the lungs, you minimize the risk of them going on, higher level respiratory support later, like a ventilator. We also might consider, or the pulmonology colleagues of ours might consider, a bronchoalveolar lavage, or a BAL, or in some cases a thoracentesis, particularly if it's like a pleural effusion or a massive pleural effusion issue, to actually, basically go in thoracentesis cases, drain the fluid between the pleural space. Or in the case of a bronchial alveolar lavage, they'll actually take a tube, they will go down into the lungs and actually, clean out the lungs and kind of suck out some of the nasty stuff that's there. And they can actually culture that and use that to help, diagnose actually what's going on. And those cultures can be very important for us to get a legitimate, culture result. The BAL cultures, tend to do pretty better in terms of, actually getting a culture, that's positive versus just the general sputum culture. So whenever we think respiratory tract infection treatment, we're thinking about community acquired versus hospital acquired. Community acquired is going to be our strep, particularly strep pneumo, um, H influenza, or H flu is what we also call it, or atypical organisms. So our atypical organisms are things like chlamydia, mycoplasma, legionella. Remember that our macrolides, fluoroquinolones, and tetracyclines provide coverage for atypical organisms. So you're always going to see one of those in the treatment of community-acquired pneumonia, because atypical organisms actually account for about 25% of community-acquired pneumonias. In regards to the most common treatment, it's going to be ceftriaxone plus azithromycin. If you have somebody that, necessarily can't get ceftriaxone or azithromycin, you can use levofloxacin or moxifloxacin. Additionally, if you have basically, azithromycin and fluoroquinolones both contraindicated, or if you don't want to use azithromycin and you want to, just, jump the levofloxacin step, you can go ceftriaxone plus doxycycline. The ceftriaxone provides, the coverage for the strep and the H flu, and the doxy provides the atypical coverage. Now, if you have a hospital-acquired infection or hospital-acquired respiratory tract infection, that can be, being in the hospital for greater than 48 hours, or being on a ventilator for greater than 48 hours, where it's called at that point ventilator-associated pneumonia. Then we will start patients on basically a little bit of everything. We definitely need gram-positive and MRSA coverage because they've been in the hospital. We need gram-negative and pseudomonal coverage because they've also been in the hospital. And in some cases, you might consider also anaerobic coverage, though it's not always necessarily required. So with the gram-positive coverage, we think our gram-positive MRSA typical things, vancomycin and linezolid. However, we don't use daptomycin, because daptomycin actually binds to the lung surfactant that's produced by the type 2 alveolar cells in the lungs, and makes it basically ineffective for pneumonia treatment. So this is one case where we wouldn't use dapto. And then additionally, we might use gram-negative and pseudomonal coverage with or without anaerobic coverage. So basically, it's kind of more or less the gambit of a variety of different things we see. I tried to list these in the most common order of what I see in my practice. Um, but it can be a variety of anything as long as you have the pseudomonal coverage and the gram-negative coverage. So Zosyn, Ceftaz, Cefepime, Ceftaz plus Flagyl, a carbapenem that's not ertapenem, levofloxacin, Cipro, or an aminoglycoside. Intra-abdominal infections usually will see symptoms of abdominal pain, nausea, vomiting, constipation, diarrhea, abdominal distension, abdominal tenderness, or bloating. Usually, we will get a CT scan to identify if there's any fluid collections or abscesses that might, actually be contributing to an infection. And we will want to try to aspirate any of those fluid collections or treat as appropriate. Sometimes, if you have certain, infections that can be easily aspirated up, maybe in the peritoneal space, you can get what's called a paracentesis, or basically they put in a little catheter and they basically drain out the fluid that's there. Um, or you may need surgery to address these things if they are related to specific organs, like, for example, pancreatic fluid collections and, some severe cases of pancreatitis. We also want to gram stain and culture those fluids if possible. Now, on the intra-abdominal side, like we mentioned, always source control is a big, big thing. So if we can drain any abscesses or fluid collections and are, basically fix things with surgical intervention if possible with our surgery colleagues, we do that first. Additionally, if we have something that is community acquired, usually we don't necessarily require pseudomonal coverage at that point. We just think about gram-negative coverage and anaerobic coverage. The most common regimens that we'll see is ertapenem on its own. Remember, ertapenem does not cover Pseudomonas, but ertapenem does cover gram-negatives, anaerobes, and it also provides an outlet for ESBL coverage with our carbapenems. A combination of ciprofloxacin and levofloxacin with metronidazole can also be used. Obviously, you see that Cipro and levofloxacin are here. They do provide pseudomonal coverage, but they still are a common, mainstay of the community-acquired intra-abdominal infection treatment algorithm. There are other options that are out there. Basically, anything that can provide adequate gram-negative coverage and anaerobic coverage is going to be fine. Ampicillin sulbactam or Unison is very common. Some of your second generation cephalosporins that have anaerobic coverage, like cefotetan or cefoxygan, can also sometimes be used, but they're not as commonly used as the first line in every single center. It depends on where you're at. You also have hospital-acquired infections, so think about these as the gram-negative, pseudomonal, and anaerobic infections. So you need to really cover all three here. The most common agents that are used are going to be piptazo and carbapenems that are not ertapenem. Another type of pneumonia that's actually called aspiration pneumonia. Aspiration pneumonia usually results from aspirating the GI contents from the GI tract into the trachea and then back down into the lungs. Usually, this happens because a patient will sometimes lose their airway or, essentially lose consciousness at some point. And because of that, they might, more or less vomit up their gut contents in kind of an uncontrolled manner. If you've ever vomited before, sometimes we try to do that in a controlled manner where we're actually trying to vomit it out. But in some cases, the patient can't always control that reflex because they might be unconscious or they might have lost their airway. It commonly happens after or during a cardiac arrest situation and in patients that have status epilepticus or continuous seizure activity where they lose consciousness. So because of that, they vomit up the gut contents. Now, sometimes that might not be as big of an issue, usually greater than 90% of the time, and some people might say up to 99% of the time. An aspiration does not cause an infection. It usually just will cause what's called a non-infectious aspiration pneumonitis, where basically it's just your stomach acid going into the lungs and causing, irritation and burning to happen. Remember, your stomach acid is very acidic. But there are some cases where you might have somebody that actually needs antimicrobial coverage because that aspiration can cause actually an aspiration pneumonia or an infection. So we usually will still empirically treat, most cases of aspiration pneumonia despite whether or not they are actually infectious or not. So we'll usually use the standard treatments that we would use for a hospital acquired intra-abdominal infection, which are the gram-negative pseudomonal and anaerobic coverages. Um, with the anaerobic side, it's not necessarily always required. We'll usually treat it for at least 7 days. Um, and in these cases, you can use Zosyn, cefepime ceftaz, combination of cefepime ceftaz and flagyl, or carbapenem that's not ertapenem. Bacteremia diagnosis is going to happen commonly because of IV lines and IV catheters, but it's also going to result from other infections also. So if, for example, a urinary tract infection hits the kidneys and you get a pyelonephritis, at that point where it hits the kidneys do get our blood flow, and you can actually get a bacteremia from that. You can get bacteremias from other things like skin soft tissue infections, where, if the skin soft tissue infection eventually goes and hits the blood, then you get a bacteremia from that, and many other, infection types. Usually, what we're going to do is we're going to obtain blood cultures always for sepsis from two different sites. In regards to bacteremia treatment, if the bacteremia came from an IV catheter, most commonly coming from an IV central line, so things like a PICC line, an internal jugular line, a subclavian line, a port, or a femoral line, all of which are central lines. Usually the treatment involves a removal or source control of the catheter. These can sometimes also happen with peripheral lines, though the higher risk is going to be with a central line. Additionally, if the bacteremia is present, most of the time in practice, we're going to still, in addition to source control, give treatment for MRSA, which is the predominant thing that we need to think about in covering whenever we have a patient that has an IV line, because the skin contains a lot of gram positives and staph. So vancomycin is going to be the most appropriate, empiric treatment for this type of infection. For other sources, just think about the original coverage of the source. So if you have a bacteremia that's coming from a pyelonephritis, you might want to cover for gram negatives. If you have a bacteremia that's coming from a skin soft tissue infection, depending on the type of skin and soft tissue infection and whether it's community or hospital acquired, you might want to cover, at minimum MRSA and gram positives, but you may spread that coverage out to also include gram negative pseudomonas and anaerobes if you have a diabetic foot infection or a hospital acquired infection of the skin and soft tissue that results in a bacteremia. Now, in regards to some of these different indications, we saw that some of them had MRSA coverage, but not all of them. But there are going to be some patient-specific factors that we're going to take into account if we ever want to add on additional MRSA coverage if we are not already covering for MRSA already. Usually, MRSA counts for about 5% of culture-positive infections in the critically ill patient population. So, some considerations that you might look at are things like prior history of MRSA infection. If the patient is colonized with MRSA, which we can get via an MRSA NAIRS test, where basically the NAIRS are actually swabbed, and if that test comes back positive, there is a possibility that that patient might, have a gram-positive infection if they are indeed septic. If they're negative for the MRSA of the narrows, you can actually consider discontinuing that MRSA coverage. If they've had a recent history of IV antibiotics, particularly within the last 3 months, if they had a history of recurrent skin infections or chronic wounds, such that we see in our long-term care population who might be in a nursing home or a long-term care facility, A pre-existing history of invasive devices like IV catheters, particularly chronic central lines like a PICC line, for example, that might need to be used to deliver, therapies to patients, over long periods of time. A hemodialysis history, because in those cases, either the hemodialysis catheter can get infected or the AV fistula that is needed to complete hemodialysis might become infected. If you had a recent hospitalization within the last 3 months, and in cases where the initial infection then leads to septic shock and hypotension. And in those cases, we're going to want to broadly cover. Now, whenever we're looking at gram-negative coverage, it's a little bit different depending on what bug you're actually looking at. So if you want to add on additional pseudomonal coverage or multi-drug resistant pathogen coverage in regards to gram-negatives, there's obviously a need for that because it is becoming more prevalent out in the world. And whenever we are taking a look at, gram-negative coverage, there can be some gram-negative agents depending on where, you are practicing that might have different resistance patterns out there. Not necessarily one gram-negative agent that covers for Pseudomonas or, a gambit of the gram-negative organisms is going to be able to target, every single organism. So in some cases, you might actually need what's called double gram-negative coverage or double pseudomonal coverage for empiric coverage if the patient has at least one risk factor. And these that are listed in the guidelines are relatively broad for the surviving sepsis guidelines, but if your local resistance patterns of specific resistant organisms might be less than 90% or less than 80%, depends on the reference that you're looking at, then in that case, you might want to actually double cover if that one antimicrobial is only going to be good 80 to 90% of the time. We obviously want 100% if possible, but that's not always going to be possible. So you might want to use two different gram-negative antimicrobials that basically cover a cross-section of your different organisms. Also, local prevalence of specific resistant organisms, the patient's risk factors for those specific organisms, then that will depend on the bug that you're looking at and the severity of illness. So if your patient has sepsis, particularly septic shock, you might want to broaden your coverage. Additionally, there are some recommendations in pneumonia guidelines regarding ventilator-associated pneumonias where you might actually have to double cover for those. The recommendations are not necessarily the strongest recommendations that are out there, but these are recommendations that can potentially save lives. Once the organism is identified from a culture, we always want to de-escalate using typical antimicrobial stewardship practices. Now, whenever we're talking about antifungal therapy, we want to consider antifungal therapy for sepsis if the patient has any of the following. And the most common thing that we would use antifungal therapy for empirically is if the patient is immunocompromised. So if the patient has a pre-existing neutropenia, if they have a predisposition for being immunocompromised, such as patients who are on chemotherapy or have received a transplant and are receiving anti-rejection medications for transplant, those are going to be some of our biggest populations where we might actually consider empiric antifungal therapy. Other cases might be if a patient is receiving parenteral nutrition or TPN, prolonged invasive catheters, like central lines or hemodialysis catheters. Major recent surgeries, particularly abdominal surgeries, are more prone to maybe have fungal infections involved. Patients who have been on broad spectrum antibiotics for prolonged periods of time, prolonged hospital and ICU admissions, recent fungal infections, multi-site colonization throughout the body, and there's many others that you might consider and that the guidelines list out. These are just some of the major ones. The main portion being immunocompromised patients. And that would be for empiric coverage. Patients who are requiring fungal coverage either empirically or for a confirmed fungus or yeast. In patients generally, if they are hemodynamically stable, at least empirically, triazoles are usually acceptable to use like fluconazole, depending on the type of fungus it actually results as. Now, in patients who are a little bit more severely ill, where they might have septic shock, where the tissue perfusion is already happening or hypotension is happening, or in patients with severe illness, echinocandins will be preferred in that case. The most common being caspofungin and micafungin, but anadulafungin is also available. For patients who have echinocandin tolerance or echinocandin toxicity, liposomal amphotericin B will be along the last line that we would use. Patients that have either confirmed or suspected influenza, a lot of times the first step is going to be to obtain either a viral culture or a flu PCR, as we'll call it, or an RT-PCR. If the influenza is confirmed or it's still suspected, we will usually treat those patients with a neuraminidase inhibitor, the most common being oseltamivir or Tamiflu. Zanamivir and perimivir are other options that are available out there, but Tamiflu is usually going to be what we go to. The sepsis guidelines don't make any formal recommendation currently for the 2021 guidelines on influenza or viral therapies. Now, if your patient actually has an unknown source of infection and sepsis, empirically, what you're going to do is you're going to treat for a little bit of almost everything. At least that's most common. So usually it'll be things like gram-positives and RMSA, gram-negatives and Pseudomonas, with or without anaerobic coverage. So gram-positive being VENC, the gram-negative Pseudomonas coverage commonly being um, Zosyn or piperacillin tazobactam, which also has the anaerobic coverage. If patients have had, prior history of, hospital exposure, you might do a carbapenem. That's not ertapenem. You can do other combinations, cefepime ceftaz with flagyl or metronidazole, cefepime ceftaz on their own, levofloxacin or ciprofloxacin, or an aminoglycoside. This might be a potential, scenario also where you might consider possible double coverage if you have absolutely no idea what's going on. And keep in mind here that the anaerobic coverage is, optional, but if you are, even having the slightest of doubts, it's probably best to just include the coverage anyway. Now, in regards to the duration of antimicrobial treatment, the 2016 and the 2021 guidelines have similar recommendations, but they also state different things relating to shorter durations of therapy and longer durations of therapy and when those are appropriate. So, shorter durations of therapy are usually and generally recommended when possible for antimicrobial therapy when possible. The 2021 guidelines say it's a weak recommendation with a very low quality of evidence. It really will depend on the patient's severity of sepsis, their illness, in addition to what's the base infection that's causing it. And you will also, be aware and learning all these different infection types, what the general guidelines for that specific infection type recommend. But it's also important to be wary about your patient and see if the patient is getting better or worse. Better clinical outcomes might lead to, needing less antibiotics for a longer period of time versus, a worser outcome, or in cases where the patient's just not getting better, we might need longer therapy to try to basically, combat that infection. Now, 2016 guidelines specifically make a comment about longer courses of therapy where they may be appropriate in patients that have a slow clinical response, an undrainable foci of infection. So basically that pathogen load, if it's too high or if source control isn't able to be obtained completely, or the infection is just staying there. If you have a bacteremia with Staphylococcus aureus, whether it be MSSA or MRSA, some specific fungal and viral infections, and some patients who have immunological deficiencies like neutropenia. Remember that patient's immune response is going to be a big part of fighting infection, but if you don't have an adequate immune response, you might need longer courses of antibiotics to basically take care of some things. So, in regards to the 3 hour bundle, we've talked about broad spectrum antibiotics and getting blood cultures and measuring a lactate level. But now, the next step that we're also going to do whenever a patient comes in is if the patient is hypotensive or if the patient has a lactate greater than or equal to 4, we're going to want to administer at least 30 milliliters of per kilo of crystalloid fluid within the first 3 hours of sepsis or septic shock identification. In regards to this fluid resuscitation that's happening, really these things are all kind of happening in tandem together. The lactate, the getting the blood cultures, the administering antimicrobials, and the fluid resuscitation are kind of steps that are kind of happening all of the same time within that first initial hour or a few hours of presentation. Now, for patients with sepsis-induced hypoperfusion or septic shock, per the 2021 guidelines, it says that we suggest that at least 30 mils per kilo of IV crystalloid fluid be given within the first 3 hours. It's a weak recommendation with a low quality of evidence. They've done a ton of data and research with looking at fluid resuscitation, and the results of fluid resuscitation and how fluid resuscitation is done is very debatable. There's been some studies that have shown, a decrease in mortality. There's been some studies that have shown no differences in mortality. And depending on how much fluid they give, if they give way too much, they might actually show increases in mortality. But in general, what we've seen across the data in regards to giving fluids is that fluids do help our hemodynamic status. And it's usually recommended that at least 30 mils per kilo be given. Now, this is based on actual body weight or ideal body weight. The times when ideal body weight is used is if the actual body weight is greater than the ideal body weight. So, in patients who are overweight or obese, you might consider using the ideal body weight. If the actual body weight is less than the ideal, then in that case, you can use the actual body weight. So, keep in mind that this is going to be for your patients who have a mean arterial pressure of less than 65, which is just 1/3 times systolic plus 2/3 diastolic, or a systolic blood pressure less than 90. Or if they have sepsis-induced hypoperfusion, where the lactate is at least 4 millimoles per liter. So this is the magical numbers to remember for when you get fluids or when you don't get fluids. Now we should, whenever we're giving the crystalloid fluid, use an isotonic fluid because the isotonic fluids are going to stay in the vasculature a little bit better than our hypotonic fluids like D5W, for example, or half normal saline, 0.45% sodium chloride, because those don't distribute very well to the intravascular space as well as an isotonic crystalloid would. Now, the previous recommendations, in 2016 and 2012, basically more or less pointed to isotonic fluid resuscitation, but they didn't say necessarily if one was preferred over another in comparison of normal saline versus lactated ringers. The 2021 guidelines actually did make a statement that if you had to pick between lactated ringers and normal saline, we would usually pick lactated ringers or ringers lactate, as it's also called, over normal saline. Part of the reason for this is there have been studies that are out there that have shown and repeatedly shown that patients that receive normal saline can sometimes have additional complications happen, like hyperchloremic metabolic acidosis. In addition to that, an increase in acute kidney injury due to the chloride load of the normal saline. Versus lactated ringers, it's more of a balanced solution. And really, what the guidelines are recommending now is that you use balanced IV solutions. So, balanced just means that it's basically similar to the human body. So, those are going to be things like LR, Ringer's acetate, which instead of lactate, it's basically just acetate, Plasma-Lyte A, or Normosil R. And there's probably a bunch of other different ones out there. The ones that I've seen in practice are LR and Plasma-Lyte myself. So if you can't, get the job done in terms of fluid resuscitating your patient, to get their blood pressure and hemodynamic status normal after the 30 mils per kilo. You can consider giving albumin, which remember is a colloid type solution, in addition to the crystalloids you've given, if the patient's requiring, a significant amount of crystalloids. Keep in mind that 30 mils per kilo is a minimum that they have to receive. It doesn't necessarily mean that all patients are just going to receive 30 mils per kilo. If you're hypotensive and the patient needs to receive fluids, they need to receive fluids. Um, and the guidelines also make statements about hydroxyethyl starches and gelatin, which are a little bit more older types of fluid administration. These are generally not recommended anymore per the sepsis guidelines. So if you want to see how actually fluid resuscitation breaks down among different populations, there is some, concern out there among clinicians about giving too much fluid to certain patients. And if you think about the most common patients who might have, a concern about receiving too much fluid, we automatically go to our patients who have heart failure. One of the big complications of heart failure is fluid overload. So the concept of giving 30 mils per kilo of crystalloid can kind of seem a little bit daunting, but the data that has been, produced out there in patients who have heart failure, who have, pneumonia, where they might also be predisposed to fluid overload in the lungs, patients who have end-stage renal disease, patients who have liver disease, all of this usually points to giving the 30 mils per kilo anyway, because the thought of the fluid administration is we're going to try to improve the patient's hemodynamic status. And in addition, if we need to get rid of that fluid later, we can get rid of that fluid with either diuretics like loop diuretics like furosemide or bumetanide, or we can get rid of that fluid by administering dialysis to the patient. Ultimately, what we're trying to do in the resuscitation phase is we're trying to basically buy time and save the patient. That is ultimately the big, big thing that we want to do. And usually this fluid resuscitation will need to be started and completed within the first 3 hours. And you just see here basically all of the different cases where you can get the 30 mils per kilo. Now, in regards to the second half of the Surviving Sepsis 2012 bundles, or the 6-hour bundle, as you remember at this step, if you do not have adequate stability in terms of hemodynamics after you administer the 30 mils per kilo, at that point you can apply vasopressors to improve hemodynamic status to maintain a MAP of at least 65. Our vasopressor support is actually pretty protocolized in sepsis. So after you give that initial 30 mils per kilo crystalloid resuscitation, at that point, you may start vasopressors. Now, the newer guidelines, the 2021 guidelines, actually make a statement and a push that even if during the first hour you're still hypotensive while you're giving fluids, you can actually start vasopressors then also. Our typical go-to for vasopressor initiation for a first-line vasopressor is norepinephrine, and that's going to be our first one that we add on. Now, if that norepinephrine dose starts to get titrated up, and these are mostly titratable drips with the exception of vasopressin, if these drips start getting titrated up to low or moderate levels where the patient is not really improving very much in terms of their hemodynamic status, we can actually add vasopressin to norepinephrine as a second line vasopressor if the MAP goal can't be attained. And for a good chunk of patients, this will actually kind of help relieve, the patient's hypotension, as patients that have sepsis and septic shock are a lot of times vasopressin depleted within the body. Each of these different vasopressors, can be found in some form or fashion already in the body. And patients who have sepsis get very vasopressin depleted. Now, if you need a third line vasopressor, if norepinephrine and vasopressin are not working out on their own, epinephrine can be added if hypotension still exists. So these are all add-ons. These are not necessarily we switch to one or the other. We're adding one each time because if we take something away, the patient's going to become potentially more unstable. Those are usually the top 3 vasopressors that are recommended in the sepsis guidelines. Now, there are some cases where you might have some complications. Now, remember, norepinephrine and epinephrine both act on alpha receptors and beta receptors. Alpha receptors are primarily found in our smooth muscle, or basically our vasculature. So our blood vessels are basically coated with these alpha receptors, but we also have beta 1 receptors that act on the heart and help our heart contract. And norepinephrine and epinephrine activate those beta 1 receptors on the heart, in addition to the beta 2 receptors on the lungs. If we are activating, that beta 1 receptor so much such that we're getting a tachyarrhythmia, and the specific tachyarrhythmias that I'm talking about are, ventricular tachycardias, SVT, supraventricular tachycardias, we can actually switch the norepinephrine or epinephrine to phenylephrine instead. And phenylephrine is purely alpha, where it's just working on the vasculature, versus working on the heart and the vasculature to increase our hemodynamic status, our blood pressure. In regards to the sepsis guidelines, they recommend dopamine as a last line, except in cases of sinus bradycardia, where you may be able to use a mid-range dose of dopamine, maybe from 3 to 10 micrograms per kilo per minute, to actually help support the heart. And that's the beta range of dopamine. The reason why dopamine is actually recommended last line will actually be discussed on the next slide. If you actually take a look at the evidence that's out there, norepinephrine compared with dopamine in patients who previously had severe sepsis actually showed an increased risk of short-term mortality, supraventricular arrhythmias like SVT, for example, and other serious adverse effects like ventricular arrhythmias. And obviously, if we can avoid those things, we're going to avoid those things. And we actually saw better outcomes whenever comparing norepinephrine versus dopamine. The better outcomes were with norepinephrine. And that's usually why we do not prefer dopamine as a first line agent, except in cases where patients have sinus bradycardia. Dopamine actually used to be kind of the first line go to back in the day, but now evidence has shown that norepinephrine is better. So if you actually summarize a lot of the stuff we just talked about in the lecture so far, the Surviving Sepsis campaign basically helped to develop what's now known as the 1 hour bundle, or the Hour One bundle. And this is obviously going to be similar to the 3 and 6 hour bundles, but these are going to be steps that you can take in 1 hour to basically treat sepsis. So a lot of the same components that were in the 3 hour bundle are now in the 1 hour bundle. In addition to the one component of the 6 hour bundle that is in the 1 hour bundle now is applying vasopressors if the patient's hypotensive. So the 1 hour bundle consists of measuring a lactate level, remeasuring the lactate level if the lactate was initially elevated after that, obtaining blood cultures before administering antibiotics if possible, administering the broad spectrum antibiotics, administering fluid resuscitation to patients who have hypotension or a lactate of at least 4, and then applying vasopressors if you're still hypotensive during or after the fluid resuscitation. So versus the 3 and 6 hour bundles previously, which said that you apply vasopressors after the fluid resuscitation, now you can actually put on the vasopressors during that fluid resuscitation period to try to support the patient's blood pressure. And keep in mind, even though that this is a nice schematic and a nice way to remember all the main steps, keep in mind that not all these steps are being done in this specific order. Even though it's 1, 2, 3, 4, 5, some of these steps might get started before other things. So just keep that in mind as you're going through this. It's more of a holistic process. This is just a schematic to show the holistic, of everything that we do. So if you have actually fluid resuscitated the patient adequately with at least the 30 mils per kilo, and have started vasopressors, but you have suspicion even after starting that vasopressor or vasopressors that your patient might have a different type of shock, or a concomitant type of shock in addition to septic shock. Septic shock is a vasodilatory shock, so it's a shock where is a problem mainly of vascular tone. We lack the vascular tone because of the inflammatory mediators that are causing the vasodilation in the vascular beds of our bloodstreams. So, if you have that problem, but then you might additionally have another problem that might be affecting, another system that governs blood pressure, such as, the heart, where you might actually have what's called cardiogenic shock, or basically an inability of the heart to, generate an adequate cardiac output on its own. Then you might need inotropic support in those cases. So the guidelines say for patients who are adults with septic shock and that have cardiac dysfunction with persistent hypoperfusion, despite giving them the flu resuscitation, um, we either recommend adding dobutamine to norepinephrine and vasopressin, usually, which will be the case, or basically using epinephrine alone compared to norepinephrine as the lone inotropic agent. So, what does this actually mean? It means that if you have someone who's on norepinephrine and a lot of times vasopressin, and you're kind of starting to see that the patient's not, getting any better in terms of their blood pressure, what you can do is if you have evidence of the cardiac dysfunction, you can either add dobutamine onto what you have already, or you can switch out the norepinephrine for epinephrine instead. Epinephrine is a little bit more potent in terms of its beta 1 agonism, and that will actually help us with our cardiac output. So, like I said, this is typically done in terms of adding dobutamine or basically switching to an epinephrine type strategy after 1 to 2 vasopressors are currently being administered, and there's evidence that the shock has a cardiogenic component. Usually it's a low cardiac output or low cardiac index, or in some cases a low SCVO2, which you can get off of a venous blood gas. So normal cardiac output is 4 to 8 liters per minute. Normal cardiac index is 2.5 to 4 liters per minute per meter squared. If you're below that, then you might have a cardiogenic component. A lot of times in septic shock, we actually are very what's called hyperdynamic, where the cardiac output and the cardiac index will actually be um, toward the upper end of the ranges for cardiac output and cardiac index normal, or they'll actually be above that. And the reason why is because the cardiac index and your systemic vascular resistance govern your blood pressure, also known as cardiac output times systemic vascular resistance equals blood pressure. So if your vascular tone or your resistance is down, the thing that's going to compensate is your cardiac output. But in patients, sometimes with sepsis, and in a lot of times pre-existing cardiac dysfunction, like patients who might have like baseline heart failure, they might actually not be able to compensate even with their cardiac output to raise their blood pressure or attempt to raise their blood pressure. In regards to oxygenation status and in terms of our oxygen supply and demand, if we have somebody who is not able to, adequately balance their oxygen status in the body, where the SCVO2 is coming out below 70%, we might need to add an inotrope in that case because it might mean that we're either consuming too much oxygen due to maybe a cardiogenic issue, or we're already starting at a low baseline for arterial oxygen saturation, which typically we like to see between 95 and 100%. We might be starting off way lower than that. So it might indicate that we need to do something. This slide just illustrates more or less kind of what we just talked about in terms of vasopressors, in terms of the adding on of vasopressors throughout the steps. So starting with norepinephrine, potentially adding on vasopressin if the MAP is still inadequate on low to moderate dose norepinephrine, which you don't necessarily need to know the doses, but generally what I consider low to moderate would be, 10 micrograms per minute or 20 micrograms per minute. And then considering additionally adding dobutamine on board or switching the norepinephrine to epinephrine instead. The last main tenet of sepsis is that if patients are, hemodynamically unstable even after two pressors, in addition to considering cardiac output and a cardiogenic component, another thing that you can add empirically is corticosteroids, because at the point where they are in that septic shock that is so severe, where they're requiring multiple vasopressors or even just one vasopressor, corticosteroids can actually potentially help regulate blood pressure in regards to steroids function in the body from the adrenal glands. And patients that have sepsis generally get depleted in this very, very easily. So the guidelines actually say that if you are on vasopressor therapy, you can add IV corticosteroids, even though it's a weak recommendation and a moderate quality of evidence. Usually, this is done, whenever you're on norepinephrine or if you're on norepinephrine and vasopressin concomitantly. Usually we prescribe corticosteroids here as hydrocortisone, usually, which are going to basically help in terms of your glucocorticoid and your mineralocorticoid balances compared to maybe some of your other steroids. Hydrocortisone 50 milligrams IV every 6 hours is usually the recommended dosing, but you can also give hydrocortisone as an IV continuous infusion, giving it 200 milligrams IV total over the whole course of a day. If you actually want to summarize all of the vasodilatory vasopressor use, so this does not include, the dobutamine and epinephrine recommendations for inotropic support. This slide actually summarizes it very well. And if you actually look on the right side as it basically goes through the titration steps, this flow diagram is actually from the 2016 guidelines. But if you basically see here, each different place where there's an asterisk is a place where you can actually add IV steroids or hydrocortisone on board, even starting at the step where you're about to start vasopressin. There's many other supportive care options in sepsis, like blood product administration if you need it, supporting patients' respiratory status, sedating and providing them pain relief, controlling their glucose, renal replacement therapy like dialysis, DVT, and stress ulcer prophylaxis, as well as nutrition support. There are, some recommendations in the guidelines about these, but we're not going to focus on these for the purposes of today's talk. Here are the references regarding this talk today. And we will go back to the case questions. So the first question related to the 72-year-old male, and we were trying to classify what his sepsis or diagnostic status is regarding infection or sepsis. And if you take a look at this patient here, based on his Q-SOFA score of 2 and his change in SOFA score of 2 from baseline, that would indicate that the patient has sepsis. We don't have any, evidence yet that the patient has progressed on. Remember, in sepsis 3, severe sepsis is no longer a definition. We do have a change in SOFA score of 2. That means organ dysfunction. And we don't have necessarily a lactate yet above 2, and we don't have vasopressors on yet, so we cannot call it septic shock from sepsis 3. The second question related to the patient's antimicrobial management. So to treat the patient's underlying infection or the patient's UTI, what antibiotic should be initiated empirically to treat this patient? The answer here is ceftriaxone. The reason why we use ceftriaxone is because it's gram-negative coverage without the need for pseudomonal coverage. Gentamicin and meropenem are a little bit too broad for a general patient with no additional pseudomonal risk factors, and vancomycin is going to cover your MRSA and gram-positives. The last question is to attempt correction of the patient's hemodynamic instability. The patient would like to start fluid resuscitation for the patient. What IV fluid should be used first to resuscitate the patient? And the answer here is lactated ringers. Remember that we're aiming for a balanced IV crystalloid solution. Ideally, that would be lactated ringers or plasmolite versus other fluids like normal saline. With that, this topic is complete. Please let me know if you have any questions as you're listening to this video. Please feel free to email me or contact me. I am more than happy to answer any questions that you have. Thank you and have a great day.